Morning, everyone.
Good morning.
So today we're going to do an overview of cranial nerves neuroanatomy. It will be a revision. I think we did in undergraduates, but I think when you look at this now, I think we'll be looking at the background. You should be thinking about application in the clinical aspects, how the nerves can be injured and how they can present in different pathologies. So when you think about cranial nerves neuroanatomy, you should think about where the nerve is, where the nucleus is, where it exits, and the supply, the function, and the structures around the distribution of the nerve and the exit of the nerve, which helps in understanding the cranial neuropathies that you see in your clinical situations. So this is a diagram that it's not so clear, but it shows the nerves from 1 to 2. We have 12 pairs of cranial nerves, and cranial nerves 3 to 12 are attached to the brainstem, and then their cell body is nuclear in the brainstem. But and this side shows the. I think this one, you look at it later. The diagram is not so clear from this. This one shows the different nuclei that we'll be mentioning associated with the different nerves that are distributed in the midbrain. As this is seen, we'll look at it later. So the cranial nerves are 12, as I said. They have sensory and motor function. Some are purely sensory, some are purely motor, and some have a mixed function. For example, the sensory, we have olfactory, optic, and vestibulocochlear. Motor, we have oculomotor, trochlear, the abducens and accessory and hypoglossal. And the mixture, we have the trigeminal, facial, vagus, and glossopharyngeal. So when you talk about sensation, the functions of the cranial nerve, there's a general visceral sensory, that's pain, temperature, touch, vibration, or position sense. And we have special visceral sensory like taste. And somatic can be somatic sensory, or that is again general or special. And this, when we go through the cranial nerves, we'll be mentioning the different exits that the cranial nerves exit through the brain. And this is important because injuries around this area or compression is significant. So we'll be mentioning the nerves, but we'll mention these exits. So olfactory nerve, which contains axons that conduct impulses of olfaction, and it's outside the meninges and below the cribriform plate, and they supply actually it's just olfaction sensation, as we talked yesterday during the examination. And then the optic nerve is also a sensory nerve that displays vision. And it takes vision from the retina, the rods, the cones, and initiates signals which transmits to the ganglion cells. These are all parts of the retina. And then the ganglion cells form the optic nerve, which passes through the optic foramen and to the eyeball, to the two optic nerves join to form the optic chiasm. And the nasal fibers, we'll go through how the important thing when you think about the optic nerve is that the nasal fibers usually...
You have to rush, I understand that. But maybe at each point, maybe we can bring out some salient clinical things. So olfactory, salient about it. So maybe we go up, just so that we look.
Yeah.
What do you think?
Yeah.
So we can just discuss anyway. So
it's not enough just to do the anatomy. We need to tell you anatomy and some of the clinical features, so that it keeps you thinking. It's affected at this level. How will the patient present? So maybe you can go back to the slide.
Did you ever see a book called Clinically Oriented Neuroanatomy?
Yeah.
So this is really what you want to do. You want to just, you don't need to know details of anatomy like these, but we need to know enough to be able to make sense of clinical data. Yeah. So let's think about the olfactory nerve. Yeah. So the olfactory nerve is really the closest optic nerve in a way to the brain. Literally sits under the brain, and it and some people would almost consider it an extension of the central nervous system, and it's very close to the CSF space. Yeah, so it has some importance. Can you think of issues that how it could be useful? How it could be useful from a clinical point of view? I mean, obviously the sense of smell is useful, but I mean, just how it could be useful from a clinical point of view. Yeah, so CSF release can happen around there. Yeah, trauma. Yeah. So in trauma, that is a nerve that is often sheared, and you can lose sense of smell. And if you lose it, it usually does not come back. Anything else?
There's any meningeal or tumor.
Exactly. So if you had orbitofrontal meningioma, or then or a contracted groove in general, then you can compromise sense of smell. Or even in any other large frontal tumor testing onto the olfactory system can compromise the sense of smell. Yeah. So even though we don't routinely test for it, it's something that one does. Is there any other importance? Probably at a higher level. So, yeah, that's true. You can get smell aura, olfactory aura. But in certain diseases like in Alzheimer's disease, Parkinson's disease, some of the neurodegenerative diseases, sense of smell is one of the first to go, indeed, in pre-symptomatic situations. Yeah? So you can actually sometimes test for that using the smell tests. So there, like the University of Pennsylvania smell identification testing, etc. Other similar tests. Yeah. So that is another kind of. So just to get you this thing, is there any basic scientific utility to this nerve? So it's one of the few areas in the nervous system where neurogenesis has been demonstrated. So nerve cells can actually, new nerve cells can form, even though it doesn't seem to result in restoration of the sense of smell. There is a lot of interest in terms of, kind of switching on neurogenesis, and if you look at basic science research, there's a lot of interest in that area. So just so we can move on.
So for the optic nerve, there's the nasal fibers and there's the temporal fibers.
So is the optic nerve a nerve?
It's like a extension of a tract.
It's actually not. Even though it's called an optic nerve, but it's actually part of the central nervous system. So when you're looking with a funduscope at the optic nerve head, which is the optic disc, you're actually looking at the part of the central nervous system. So we have direct visual access to the central nervous system through the eye, and that is why the eye is often considered a window to the brain. Yeah. Okay. So that is one thing to keep in mind, and it again has importance in terms of how mental diseases manifest.
So as I was saying here, the nasal fibers cross. This is the lateral geniculate nucleus, and then it radiates into the optic radiations. And here the superior becomes the inferior as it approaches the occipital lobe, and this is the calcarine fissure of the occipital lobe. So all this takes part, this is all the visual tract, and it's important to understand how the fibers, the tract is, because it can help in, depending on how the patient manifests, you can predict the area at what point the injury could be. For example, any clinical scenarios you could think.
Pituitary tumor, optic nerve.
Temporal lobe inflammation, tumor.
So let's think about the pituitary, just as an example. So tell us more about it.
So a pituitary tumor sitting at the optic chiasma will compress mostly the temporal, and then you lose the temporal vision fields.
So where is it compressing? So where is the chiasm in relation to the pituitaries? So the pituitary is inferior to the chiasm, isn't it? So when you have a small adenoma of the pituitary, does it bother the chiasm? No. It doesn't. But as it grows, and if it grows upwards, which it often does because the lateral margins are bony, then what happens is it begins to compress the chiasm. And obviously, which part of the chiasm will it compress? The center, the median part of the chiasm, isn't it? Yeah. And so if you compress the median part of the chiasm, which fibers are you compressing?
Yes.
Yes. So you're compressing the nasal fibers, and thus you're losing temporal sheath. Yeah, okay, all right. So if you have that anatomy in mind, you can work out a visual field defect in its anatomy correlation. Yeah, okay. So, and then there are many other examples, but just to kind of give you. So this is something that's worth playing through one's mind a few times with the diagram. So. Kind of pinning it up in your bedroom, yeah, instead of Roger Federer's photograph, yeah, might be a good idea, yeah, and it might not be very popular, but it's a good way of playing because this is a skill that you can use way into the future, yeah, whether you're an endocrinologist or a neurologist or a general physician or
And it's something that, as the doctor said, it won't come instantly. You get to know much sooner.
Yeah.
So there's the lesions which are anterior to the chiasm and then the others which are posterior. And then other than the optic chiasm is the commonest, but you also have the optic radiations in many patients who have strokes, the infants involved with parietal lobes, retinal lobes. So it's those subtle differences. Is it a contralateral, frontalupial, is it a luminous? As you go, continue seeing patients, you go back to get very excited because you can actually see it maps out. So if a patient has an impact in the parietal lobe, where will the lesion be on the visual field? If it's a temporal lobe, there will be. So those are very small details, but you can check them out.
So it also takes part in the pupillary light reflex. So the afferent nerve is the optic nerve that carries stimulus past the lateral geniculate nucleus we saw to the endiga-westphal nucleus, which is a kilometer nerve nucleus in the midbrain, and that will stimulate constriction. And so the motor response travels by the kilometer nerve to the pupillary sphincter. And both pupils constrict when one is stimulated due to the fact that the endiga-westphal nucleus is stimulated by the optic nerve. So we saw this yesterday. When you examine for optic nerve, you look at the pupillary reflex. Then the oculomotor nerve. So it emerges from the ventral aspect of the midbrain. It travels through the cavernous sinus. At the end, the cavernous sinus is important, so I'll be mentioning nerves that pass through the cavernous sinus, but at the end we look at the relations. And then it passes through the superior orbital fissure, and it gives a superior and inferior branch. The superior branch supplies the superior rectus and the levator palpebrae, and the inferior branch supplies the inferior rectus, the inferior oblique, the medial rectus, and the parasympathetic innervation to the ciliary muscles and also to the circular muscles. So what's a mnemonic to remember the extraocular extraocular muscle supply? Is it 6? So if you have a palsy, an oculomotor palsy, yesterday we talked about it, how down and out, because it will be the SO4 and LR6. So we talked about that it constricts, it takes part in parasympathetic to constrict the pupil. This is just a diagram that shows the superior orbital fissure and the superior and inferior branch that supplies the extraocular muscles, and also the parasympathetic and also the levator palpebrae muscle.
So when is the levator palpebrae important? Okay, so in cranial palsy, what do you expect? like with your symptoms, isn't it? Yeah.
So trochlear nerve.
And also for the neuroanatomy, we discussed this, that we also need to put a bit of emphasis on where the parasympathetic fibers are applied. And if you have how do you differentiate between a surgical and a medical, I think we touched a bit on that. Kelvin, can you remind us?
Doing
Surgical and the medical and why? Because this forms an important part in patients here every day. The oculomotor nerve is important.
Eventually just forgotten.
Surgical, because we have an aneurysm that will bring on the course of blood. This is
So your patient presents with an oculomotor nerve palsy, but the pupillary function is preserved. What do you think about?
It's a medical, so the parasympathetic is more outward, so when it's compressed, it will be like an aneurysm, which is more surgical, so it affects the pupils. But if it's the pupils are preserved, it's more of the inner, so like a medical, like a stroke, so to be, the pupils will be.
So when you talk about a medical nerve, you're talking about a microvascular occlusion of the vessel nervosa of the oculomotor nerve. Yeah. And so what that usually does, I mean, it can do it to the whole nerve or sometimes a fascicle of the nerve, but essentially what it does is it causes a small impact of the length of one portion of the nerve, and that then results in loss of conduction across the nerve. So there's a fault in it. Yeah, okay. But most of the time that the kind of parasympathetic fibers are spared. Yeah, okay. So you have unopposed sympathetic activity and you have dilation. So most of the time the autonomic things are spared, so the pupil function is normal. Yeah. But as opposed to a surgical one where you have, compression of the nerve, and in that case often the whole system is damaged. But like was mentioned yesterday, it's not completely separate, and sometimes you just have to make sure you image to differentiate them. Yeah. If there's any doubt, you image. Yeah. And there's some rules about that.
Then another clinical significance is that if you have the oculomotor nerve is close to the posterior communicating artery, and if you have an aneurysm associated with the posterior communicating artery, most of the time you'll have a manifestation of as a third nerve palsy. Then the trochlear nerve, this is the smallest nerve, and the nucleus is located in the dorsal midbrain anterior to the aqueduct. And it travels dorsally, decussating and exits the posterior midbrain before traveling to the cavernous sinus, important also, through the superior orbital fissure to the superior oblique. What's the function of the superior oblique?
It moves the eye down and in.
Sorry. Did she sit down and leave? I think it's down and down.
Depression and torsion to keep your shoots down and in.
So you're looking this way and then this way. So if it's the right time, yeah. So this is rear rectus. I mean, yeah. So this is this is inferior. This is superior oblique, inferior oblique. So this is going this way. So the eye is going this way.
I think it was the inferior rectus that causes downward motion and adduction. I've always had a small problem there because there are some books that actually say down and out for inferior oblique, or some others say down and in for inferior oblique.
What I suggest, why don't you bring those sources if you can bring them, even photograph them or something, let's sit down and discuss.
This is actually
So we're looking on the staircase.
Yeah, I think it's a good way to remember that.
I have the Grey's Anatomy. Which actually has a diagram of that. Because the other thing it will explain is the motion once you get a tracking nerve palsy, you expect it to go down and out because of one of those superior oblique action.
It's a very weak attack. Superior. Down and out as well. Yeah.
Yeah, because
A bad nerve palsy, so you have an opposed superior oblique activity.
and lateral.
And lateral rectus.
So looks like this is what
Is that
this way. But the superior oblique is pulling it down.
Yeah.
So that is correct. But we expect to pull it down, but the outward motion is from the lateral.
Yes. Just very good to stand and feel
The reason why I always believe this version is because of when you are actually dissecting, it because we actually used to do the superior rectus and it actually was when you actually, according to where they attach in the relation to the whole, the optical pole versus the pole of the
Isn't this exactly what we are saying?
the superior oblique goes down and out, down and
It depends what you mean by out and what you mean by in. So you see the eye is in this position and it is being intorted in going this way towards the inner campus. Okay? But if you think that it's being pulled this way, then you could argue that it is being pulled out because it's pulling in that direction. But actually, by convention, you're pulling it towards the inner campus. So it really, I think the only difference between what we are saying is where you keep your reference point. But I think we agree. You accept?
So we'll go to the trigeminal nerve. It's the largest
So for
cranial.
the trachea, it's only nerve that it's on the dorsal of the brain and it has a long course. That's why it's very easily gotten trauma.
So the trigeminal is the largest cranial nerve and it lies in the floor of the middle cranial fossa on the petrous temporal bone, and it is a mixed nerve that has both motor and sensory function, a large sensory one and a small motor root. And it has three branches: the ophthalmic, the maxillary, and the mandibular. So the ophthalmic is the smallest branch. Of note, we should note where all this will be exiting. So,
and just another thing, it's got a large nucleus. So its nucleus starts from the midbrain and goes all the way into the upper cervical cord. Yeah. So it's got a huge nucleus. Yeah. So you could potentially get facial sensory problems from an upper cord problem, simply because of the length of the
yes. So the ophthalmic branch emerges from the ventral aspect of the pons and then travels through the cavernous sinus and enters the orbit through the superior orbital fissure. And we saw yesterday it supplies the skin over the upper eyelid, the eyeball, the lacrimal glands, the nasal cavity, the side of the nose, the forehead, and the anterior half of the scalp. Then these are just the branches. The maxillary branch is an intermediate in size. It travels also through the cavernous sinus, enters the foramen rotundum of the sphenoid, and it contains sensory axons to the mucosal layer of the nose, the palate, the part of the pharynx, the upper teeth, the upper lips, and the lower eyelids. Then the mandibular branch is the largest branch, and of note, it does not pass through the cavernous sinus, and it exits through the foramen valley of the sphenoid. And it contains sensory axons to the anterior 2/3 of the tongue, the cheek, the mucosa, the lower teeth, the skin over the mandible, and the side of the head anterior to the ear, the mucosa of the floor of the mouth. And so the sensory axons from
That sensory distribution is best illustrated with the diagram, isn't it? Because you won't really remember all that verbiage. Yeah, so that's probably the best way to remember.
Yeah.
Yeah. So, but there's one problem with the diagram. There's there's a cutoff at the back. Yeah. So this is not all.
Yeah.
Okay. And up to here. So even here, this corner. Okay, so the diagram is erroneous. This corner is actually C2.
Yeah.
Where is C1?
It's not sensible.
Remember when Dr. Soki was saying when you examine, you don't point. Yeah. So the somatic motor axons of the trigeminal nerve supplies the muscles of mastication. Examples, Beverly? Farah? Temporalis. Okay.
It also has a special efferent in the posterior belly of the digastric muscle.
The anterior belly.
Anterior belly of the
Mhm.
digastric.
And also the tensor tympani, the tensor belli palatini, and the mylohyoid. And it takes place in reflexes, the corneal reflex, although we clinically most of the time we don't examine this, the jaw jack, and also the stanitatory. So we've gone through that. We talked about the nucleus. It has a large nucleus. So we were saying about the spinal trigeminal nucleus. It's a long nucleus that extends from the midpoints down to the spinal cord. And it's the nucleus for pain and temperature of the face. There's also the mesencephalic nucleus that's located in the brain. There's the pontine trigeminal nucleus, or the chief sensory nucleus, that receives light sensation from all the three divisions, including corneal stimulation, and it's also located in the midpoints. And of note, the trigeminal nerve also supplies nociception to the dura mater and associated vessels, and all the three branches contribute to this. So the abducens nerve, part of the extraocular muscle nerves. So it's a motor nerve. It's located at the fourth floor of the fourth ventricle in the pons, and it exits the pontomedullary junction before entering the cavernous sinus and proceeding through the superior orbital fissure to supply the lateral rectus. I think this is straightforward. The facial nerve. So the facial nerve, the nucleus is located in the pons.
What's special about the
abducens nerve?
Yeah.
It's a long cranial.
Sorry.
It's a long cranial.
Okay.
Anything that shows that
So anything that increases pressure can press the nerve and cause problem. So it is a classic false localizing site. So you can't use it as a way to localize the lesion. There are many other cranial nerves that can give you false localizing site, but this is the biggest one.
I'll put at the end as a red, yes. Yes. So the facial nerve is located in the caudal pons at the level of the abducens nucleus, and it sends a branch to the stapedius, which dampens loud noises, and the patients usually present with hyperacusis. And then it continues through the stylomystid foramen to the sending branches to the stylohyoid and the posterior belly of the digastric, and then the remaining branches supply the muscles of facial expression. These are the 5 branches: the temporal, the zygomatic, the buccal, the mandibular, and the cervical. We talked about this, the branches. So it takes part in tears, in snoot, in drool. You'll read through the nucleuses that are involved. There's a superior salivatory nucleus, and it travels through to the geniculate ganglion. Then it subserves tears and snoot, then travels down the greater petrosal nerve to the pterygopalatine ganglion, and then there to the lacrimal gland, and also to the nose and the sinuses. And then also travels to the submandibular ganglion, to the submandibular and sublingual glands. So it also supplies taste to the anterior 2/3 of the tongue, and also skin sensation over the ear, the auditory canal, and the tympanic membrane. So what's the clinical importance of the facial nerve? Important clinical.
It's commonly involved in cerebrovascular accident because of the location of its because I've said it's commonly involved in cerebrovascular accident and commonly with find facial nerve accident patients
Because
have
of what?
NCA territory.
Yeah, is that so? You said
It is.
something there.
Is it?
You said something before.
I said because of the location of its nucleus.
When it exits the skull, exits to say this thyroid, it's called thyromas. Yeah, it has a small exit. Any inflammation to the cranial nerve, the facial nerve can give you Bell's palsy, which is at the back of the ear, where it exits into the skull. That's one. The other thing, it can give you hyperacusis. Another significant dental procedure can cause bones. It has a branch, the lingual nerve. It's very close to the mucous.
The lingual nerve is a branch of the
Yeah, okay.
trigeminal.
Yeah. The lingual nerve is a branch of the trigeminal, but it has, is it parasympathetics that go along with the lingual, so that when you have dental procedures, you can actually use test the tongue, especially at the back. This close to the second molar or third molar, something.
So the issue of the involvement in stroke, I think it's because of the radiation, the cortical pattern radiation, and that's why it was an
So it's not really the nucleus. In some patients for stroke, you can, like upon head stroke, you can involve the facial nerve nucleus, but in the majority of patients, most of the like cortical strokes or lacunar strokes in the capsular strokes, these strokes actually involve the fibers, the upper motor neuron fibers, and that is why it's important to distinguish between upper motor and lower motor neuron facial neurosis. And what's the distinguishing things like? Yeah, so sparing of the upper face, yeah? So relative sparing of the upper face, let's put it that way, yeah? So that and that is because of dual elevation of the upper, yeah, okay? So you can get sparing of the upper face, you'll be able to crease your forehead, and the eye closure may be stronger than in lower motor neuron.
Because of the long intrapetrosal course to close compartment, so it is very susceptible to pressure.
A little bit of swelling.
Okay, so we've talked about the upper motor and lower motor differentiation is very important. We'll go through the vestibulocochlear nerve. It's a sensory nerve. It has two branches, the vestibule and the cochlea. The cochlea takes place, it's an auditory. It receives sound waves from the tympanic membrane, that is transmitted through the ossicles to the oval window into the cochlea. And then the cochlear fluid jiggles and the vibration is picked up by the cochlear nerve. Then it travels by the internal auditory meatus to the medulla to synapse in the ventral cochlear nucleus and the dorsal cochlear nucleus. And of note is that from the nucleus up, you should note that the systems are bilateral, such that any unilateral lesion that is beyond the cochlear nucleus will not block auditory information from reaching the auditory cortex beyond the nucleus. So if it's below this, it can block, but above this, any lesions here cannot block. And then the system from the cochlear nucleus to the cortex, from here it's bilateral. So if you have a unilateral lesion affecting any point above this, there'll still be transmission of auditory information to the cortex. Then the vestibula is the balance. It's comprised of the labyrinths, the utricle and the circle complex, and the semicircular canals. And they detect position relative to gravity, and they detect movement in any plane. And in the vestibular nerve proceeds to the cochlea, to the rostral medulla, to synapse with the vestibular nucleus. And also the vestibular input is also supplied also by other nerves that will compensate, like for compensatory eye movements, also by the spinal cord for maintaining posture, and the cerebellum so that you make suitable limb adjustments. So the balance is an interplay between the vestibular nerve and also other function, other contributions. And of note, if you have a cerebropontine angle lesion, it can disrupt activity of the vestibular or cochlear nerve. Any other clinical significance anyone can think of the vestibular cochlear nerve?
I think one of the aspects is to differentiate it from posterior and posterior circulation. So whether it's a cerebellar central lesion or it's due to vestibular cochlear.
I think that's important because I think we'll go through this on Friday, dizzy patients, because we said the balance is a contribution of many other factors. So the glossopharyngeal.
So if you have a cerebropontine lesion, the commonest of which would be vestibular. For example, so what deficits would you expect and how would you correlate that anatomically? Balance may be affected. Why?
Because of the vestibular nerve.
Yeah, so the vestibular nerve.
And then hearing because of the cochlear nerve.
Yeah.
Also motor function to one side of the
So you may get facial nerve involvement. Yeah. So if we press at the pons or the exit of the, the trigeminal, some of the lower trigeminal, so you can get sensory, facial sensory involvement, and also obviously by pressing on the brainstem, you can also get other, so pyramidal, contralateral, pyramidal sensory, or balance, exaggerated balance issue because of the involvement of the brainstem. So that is just to, bring up the whole issue of how the pathology is related to the brainstem.
Then the glossopharyngeal nerve is motor and sensory. It supplies the stylopharyngeal muscle, which elevates the pharynx during gag, and also it supplies taste to the posterior third of the tongue back to the solitary nucleus. So we usually talk about this. Taste. Yes. And then it receives sensory information from the skin, from the back of the ear and the tympanic membrane, but it supplies to the spinal nucleus of nerve 5. And also it has baroreceptors. It receives information from baroreceptors in the carotid sinus and chemoreceptors in the carotid body, and sends information about the BP and oxygen levels back to the solitary nucleus. And we talked about Joule. It has the inferior salivatory nucleus that sends parasympathetic fibers via this nerve to nerve V3, which is the mandibular branch of the mandibular branch of oculomotor, and from there to the parotid gland. So it exits the skull through the jugular foramen, together with the jugular vein, cranial nerve 10, 11, and also near 12, and also near the carotid artery. So they are in close association. So branches, we'll go through the branches, but we've talked about the main branches to taste, to the pharynx for gag reflex, to the carotid sinus, to the baroreceptors. So that's the importance of the glossopharyngeal nerve. Any significance? But we can talk with also cranial nerve 10, then we talk together about it.
So I think it's also injured in operations of the parotid gland.
Yeah, important.
But which is the nerve which is most injured?
Facial.
Why is that? Yeah, so it actually branches within the.
We have the vagus nerve, which is a mixed nerve. The motor fibers arise from the nucleus ambiguous, and they proceed through the jugular foramen to innervate the muscles of the pharynx and the larynx. And important is the recurrent laryngeal nerve, which innervates the intrinsic muscles of the larynx after wrapping around the vessels. Importance of the recurrent laryngeal nerve. Yeah, during thyroidectomy. And then parasympathetic, it has important connections to the heart, to the lungs, and to the gut, and it originates from the dorsal nucleus, which lies in the medulla of the floor of the fourth ventricle, and it travels through the jugular foramen, then to the appropriate ganglia. So we've said visceral sensation, it receives information from the gut, the lungs, and the aorta, and travels back to the brainstem via the solitary nucleus. And it gets baroreceptors in the aortic arc to register pressure, chemoreceptors in the aortic bodies to register oxygen concentration. And it triggers reflexes that are involved in regulation of the visceral processes. Importance, vagus nerve clinically.
Brainstem regions. For example, one should be posterior inferior cerebral artery. It can affect lateral mechanism.
So these are just the branches to the vagus. The accessory nerve is a pure motor, and we talked about it yesterday. It supplies the ipsilateral sternocleidomastoid and trapezius. Trapezius you examine through shrugging, and the sternocleidomastoid through the neck movements. I think this is straightforward. It moves through the jugular foramen. We talked about together with the other nerves, 9 and 10. And of note, the nuclei consists of the aspects of the ventral brain through C1 through C5. So there's a spinal component to it. And it passes through the foramen magnum. So if there's any like herniation or any pressure through the foramen magnum, it can be involved. Then the
there is the spinal accessory and there is the cranial accessory. And the cranial accessory is being, so the 9, 10, 11 are involved in innervation of the pharyngeal laryngeal musculature. Yeah? But the spinal accessory is really just a joyrider on the nerve, yeah. And so the roots are actually spinal, but they are just joyriding on the nerve. But they are not originating from the brainstem as such, like you said, yeah. So there are two components to the nerve. There is the cranial, which is actually involved in this, but you can't tease them out. So when you're examining the throat and speech, and you're actually examining 9, 10, 11 together, yeah, because you can't really tease them out in terms of motor function, yeah. And then when you're so the only kind of differentiating clinical sign would be the spinal accessory, the shoulder shrug, so the trapezius and trapezius and sternocleidomastoid function. So those you can do as a differential, but not the cranial.
Then the last, the hypoglossal nerve. It's a motor nerve that moves the tongue, and the nucleus lies in the dorsal medulla, and the fibers exit between the pyramids and the inferior olive, and it passes through the hypoglossal canal on its way to innervating the intrinsic muscles of the tongue, as well as the extrinsic muscles of the tongue. And of note, the tongue receives cross innervation from the cortex. So, any clinical significance about this hypoglossal nerve? I think we mentioned yesterday.
So it depends if you have a stroke on the side of the lesion. So if you push your tongue, let's say outwards, and it deviates to the left. So the lesion is on the left because it's moving towards the lesion.
Anything else? Yesterday, Dr. Soki mentioned about is the time it can move to the same side, but
It's an upper motor lesion, which she describes to move towards the lesion. If it is a lower motor lesion, so the muscle works by pushing. So if it's an upper motor lesion,
It's a lower motor neuron lesion
towards the lesion.
towards the lesion.
If it's an upper motor, you move towards the lesion.
away from the lesion.
With upper motor neuron lesions,
What's inside of this one?
Sorry, I don't understand how that works. So it's
so with upper motor neuron lesion, usually you don't get that much of a problem. You get more of a spasticity, long-term lesions like motor neuron disease or things like that. But in lower motor neuron lesions, they usually a clear problem. So the deviation is usually to the side of the lesion. But for example, if somebody has a stroke, yeah, and they have a facial nerve palsy, then what will happen is sometimes you will get a false impression that there's a hypoglossal nerve palsy because the tongue is kind of falling to that side. But the way to check for that is they protrude the tongue and it comes out relatively straight. And then as they put it in, it also goes relatively straight. Well, in a true unilateral hypoglossal nerve lesion, what you'll get is the tongue protrudes to the side of the lesion, and then as you retract it, it goes to the opposite side. Yeah, okay? And that is a true unilateral hypoglossal nerve lesion. Yeah? And that is because of that pushing action. Yeah, okay. Any others?
No.
Yeah. Does that make sense? Yeah. But like she said, because of this bilaterality of control of the tongue, because the tongue is, some of these things are very conserved. There's a lot of redundancy, and the reason is because the tongue is central to speech. So because of that, with unilateral upper motor neuron lesions, so for example, if somebody had a unilateral stroke, you don't really find much of a hypoglossal nerve palsy as such, but you may get, especially with bilateral lesions, you may get spasticity coming in, and that's where the tongue movements are slow. Or there may be apraxia, where there is a problem either motor commands,
Then this is a diagram just showing the relations in the cavernous sinus. Any comments on this? Alrighty.
So again, this is a diagram where kind of filling up in the loo or so maybe put it. No, maybe what I should say is put it as screen, so because that's where you look. And nowadays, maybe that's the better thing to say. So.
We already talked about it.
Sorry?
I think we already talked about it.
Yeah, we did, yeah. But what I meant is, again, this is something that we need to kind of have a visual kind of memory of, because it comes up every time. And can I say something? All these cranial nerves and all these nerves and their branches and all that, it's useful to have a general idea, but it is absolutely no harm looking it up. Yeah, okay? So when you're faced with a patient, I look it up. Yeah? We all do. Because it's impossible, except if you're kind of an expert in that area, to remember each and every branch and each and every nerve root sometimes. Yeah. If you're not sure, look it up. And the other bag I used to have had actually a little book with all those roots and everything. I mean, so it just there's no shame in looking it up. Yeah, nothing wrong. It's everybody does, including the most senior neurologists around, including the experts, including even the neurosurgeons when they are about to operate on this. They will actually look it up just before they are operating, because you really want to be fresh with your memory of what you're looking for. So, for example, if somebody has just a little patch of numbness, you're not sure which branch it is, but it's fine. But obviously, you'd be expected to have some memory of these things. Why? Because we need to have a certain, we all need to have a certain kind of standard basic knowledge. Yeah.
So if you have a pathology in the cavernous sinus, you expect involvement of what you've listed below, and you should not, like for the trigeminal nerve branches, the mandibular branch is not involved in the cavernous sinus pathology, just the ophthalmic and the maxillary branches. There's the internal carotid, which is in close proximity, and the pituitary gland. So any pathology affecting there, we expect involvement of these nerves. Dr. Silva, any comments?
So how you can, we always go back to the next, but it's good to have an idea. Like for this, how you look at what structures are more lateral and what structures are much more towards the median. So that if you have a lesion link, you have involvement of the form, and probably the ophthalmic and maxillary divisions as opposed to if you have more of the absence, where with the lesion you can also see the blood vessel in kind of carotid function. And also the sympathetic fibers writing on it. It's good to have an idea. Because if you have some lesions affecting the cavernous sinus, which very commonly come up, at least you can know what combinations of cranial nerve and what. That's good.
Where does the cavernous venous sinus come in this? Because even they can do some sort of pain.
So this is the cavernous venous sinus.
The entire thing.
That's the cavernous venous sinus.
So a thrombosis.
Yes, so if you get cavernous venous sinus thrombosis, those are the things that you expect to get involved. Yeah. And that is why it's so important. In the days of uncontrolled infections, that was bleeding, or it was lack actually. Now it's less common, but we do still see patients occasionally with cavernous venous sinus.
Especially diabetic patients, conscious that gluconeosis is very common for cavernous.
In CP angle lesion, you said the nerves that are involved are 7, 8, 9, 10. It's 10.
No, so 7th and 8th are primary.
Yes.
Yeah. But then you can, as the tumor pushes
Yeah.
medially, it can involve, trigeminal, or certainly compress the brainstem. So that's what I meant.
You can also get cerebellar.
Yes, yeah, but yeah, you can push the cerebellum, but also through the cerebellar connections with the brainstem.
We've come to the end.
And then another nice cross-section would be probably the brainstem, like for the lateral medullary.
Yeah.
Commonly, yeah, lateral medullary, medial medullary, where the motor function not so much involved in the lateral medullary. So you know where your structures are. Which ones are medial? Which ones will be involved in medial medullary? In fact, and which ones are lateral? End of presentation.
Do you have a reference for the? Do you have a reference? So if somebody wants to read, where do they read?
So for this one, for the cranial nerve thing,
Yeah.
so I think the clinical oriented neuroanatomy, the basics neuroanatomy books we read in undergraduate, and I think those are the main.
So what was your main reference for this presentation?
So my main reference was not that clinically oriented, was the name of this book, the anatomy. Keith Moore.
Right. All right. Okay. Fine. Okay. So the other, so kind of from a more clinical perspective, there's a book called Practical Neurology by Jose Miller, which is very nice. And if you, in terms of illustrations, there's a book called Neurology and Neurosurgery Illustrated, which is a fantastic reference, and it has got, line drawings, no color diagrams, but line drawings, which are fantastic. Yeah. So you can use those two as kind of reasonably good references. And Harrison's is actually a very good textbook of neurology. It has got some of these things are very well described because the person who's written that fantastic. So those are just from my point of view.
Is it important also to know things like the vestibulo-ocular reflexes? Because she didn't mention that much in this slide.
Right.
There are these other reflexes of how when you look laterally, how it causes the medial rectus to move.
Sure,
Are
yeah.
all these reflexes also important, or should we just know the main ones that she shared?
They become more important as you go into more neurology, and obviously in clinical neurology practice they're very important. But I think at your level at the moment, I mean they're important to know about, but I don't think one is really kind of too much. Yeah. But you need to know them enough to be able to examine a comatose patient. And again, some of these things will be covered in terms of actual clinical work and in terms of, like for example, I suppose when you're part two, the session they are doing just now, some of those things will be discussed. Yeah. So that's important. So, like caloric testing for, and things like that. So those are issues that.
The very many of things to focus on the so those you pick up as you go through. For your stage right now, I think knowing the anatomy and the clinical information that we discussed. But as you find patients you're finding, as you go more into your third and fourth grade.
And the best way to learn is to read around the patient. Okay.
Thank you.
Thank you very much.